Welcome to our video on hypovolemic and cardiogenic shock. Let's get started. So here's our overview slide, and we'll start by talking about hypovolemic shock. And for both of these types of shock, we'll talk about the definition of it, the causes of it, the hemodynamic parameters that you need to know, as well as clinical features, diagnosis, and most importantly, how you manage it. So hypovolemic shock is characterized by insufficient organ perfusion due to intravascular volume depletion. And it's usually caused by conditions that can cause a decrease in the circulatory volume. So, for example, dehydration of almost any cause, such as severe vomiting or diarrhea, those activities can significantly reduce the plasma volume. And then, naturally, bleeding can directly deplete the blood volume. And then finally, burn victims are at risk for hypovolemic shock because that burned skin really can't prevent that fluid loss. Now, before we discuss the changes of hemodynamic parameters in hypovolemic shock, let's briefly review each item. So, the central venous pressure, or CVP, is the pressure in the central veins. So, what we're thinking of here specifically are the superior vena cava and the inferior vena cava. So, the central venous pressure is approximately equal to the right atrial pressure, and it's directly proportional to the right-sided preload. So there's actually two ways you can measure it. You can do it directly via a central line catheter, or you can estimate it based on the jugular venous pressure. Okay, so that's CVP. Now, pulmonary capillary wedge pressure, or PCWP, is the pressure in the pulmonary capillaries. And you measure this via right heart catheterization with a Swan-Ganz catheter. And the pulmonary capillary wedge pressure is approximately equal to the left atrial pressure, and it's directly proportional to the left-sided preload, which is why the Swan-Ganz catheter can find out the pulmonary capillary pressure, because it's basically equal to that right atrial pressure. And next is the cardiac index. This is the cardiac output per body surface area. And although cardiac index can be measured by various diagnostic modalities, it's usually commonly estimated via a Doppler ultrasound. Next, we have systemic vascular resistance, or SVR. The whole point of this is to be an indicator for peripheral vascular tone. And it's calculated based on the mean arterial pressure, so MAP, and the central venous pressure, or CVP, which we discussed earlier. Now finally, the mixed venous oxygen saturation, or SvO2, is the oxygen saturation in the pulmonary artery, and it's affected by oxygen uptake in the capillaries. And you measure this just using a venous blood gas. And with that background, let's dive again into the hypovolemic form of shock. So, due to severe volume depletion, both central venous pressure and the pulmonary capillary wedge pressure are decreased. And since that venous return is low, cardiac index is low as well. And that decreased cardiac output causes reflex sympathetic overactivity, and that will then constrict the peripheral vessels, which increases systemic vascular resistance. Now finally, since blood flows very slowly in capillaries in the setting of hypovolemic shock, then the tissues will extract lots of oxygen. They're going to get everything they can while they can. So, the mixed venous oxygen saturation will be low. Now let's talk about the clinical features. So hypovolemic shock is characterized by hypotension and tachycardia. And in this case, tachycardia develops to compensate for that decreased stroke volume. In other words, hypotension occurs, and then the heart starts beating faster. And the skin is usually cold and clammy due to peripheral vasoconstriction, again from that overactive sympathetic activity. So how do you diagnose it? Well, you diagnose hypovolemic shock based on the combination of the patient's history, that is, identifying a cause of volume depletion, and then also the measurement of the vital signs and the hemodynamic parameters. So for example, vital signs, you'll see blood pressure low, heart rate high. Hemodynamic parameters, you'll see basically everything low, central venous pressure low, pulmonary capillary wedge pressure would be low, cardiac index would be low, the mixed venous oxygen saturation would be low. The only thing that would be high is the systemic vascular resistance. Again, that's because of the sympathetic activity. So once you've identified that a patient has hypovolemic shock, you got to manage it. And you do this with IV fluid resuscitation. So usually bolus IV fluids are administered to stabilize the patient first, and then the patient can receive maintenance fluids. And the fluids most commonly used are isotonic solutions like normal saline or lactated ringers. You'll often hear that referred to as LR. And the isotonic fluids are actually preferred most often because they replete the volume without changing the plasma osmolarity. But in many institutions, they just use lactated ringers regardless. So you can see it doesn't totally matter. The whole idea is that you just want to give them fluids. Now lastly, clinicians should consider a blood transfusion in the setting of significant blood loss. So hopefully that's pretty intuitive. You've got this patient that has hypovolemic shock and they're hemorrhaging everywhere. So it's clear that the reason they are hypovolemic is because of blood loss. So of course you're going to want to give blood. So now let's do a quick question. A 29-year-old man is brought to the emergency department due to a gunshot wound to his abdomen. The vital signs include a blood pressure of 60/50, a heart rate of 160, and a respiratory rate of 24. Physical exam reveals a bleeding wound. What change is expected in this patient's mixed venous oxygen saturation? Okay, so clearly this patient is losing blood. The vital signs reveal severe hypotension, and you can see the bleeding wound, and all of that is consistent with hypovolemic shock. So, due to the decreased cardiac output and that increased SVR, then the blood flow in the capillaries will be slow, and the tissues will extract as much oxygen as they can as that blood slowly goes through. So, the mixed venous oxygen saturation will be low. Now let's move on to cardiogenic shock. And here's a reminder of the sequence that we'll be following with this condition. So cardiogenic shock is insufficient organ perfusion due to cardiac dysfunction. And cardiogenic shock can be caused by anything that can impair cardiac output. So here's where it's really important to remember this equation. So cardiac output equals the stroke volume multiplied by the heart rate. So keep this in mind as we go through these ideas. So myocardial infarction can acutely decrease cardiac contractility. So it decreases stroke volume. So that will cause insufficient cardiac output. Patients with congestive heart failure exacerbations can also have an acute drop in myocardial contractility and the stroke volume. So stroke volume goes down, so cardiac output will go down. Now, potentially any arrhythmia can also cause a cardiogenic shock. Now, tachyarrhythmias decrease the diastolic filling time and the preload, which in turn lowers the stroke volume, so there's less time to fill up. Now, bradyarrhythmias, on the other hand, severely decrease the cardiac output by decreasing the heart rate. Now, finally, valvular defects can result in cardiogenic shock. For example, if a patient has severe aortic stenosis, then left ventricular outflow can really compromise the stroke volume. And if the stroke volume goes down, then the cardiac output will go down. So what are the hemodynamic parameters of cardiogenic shock? Well, since myocardial contractility is acutely decreased, at least in most cases of cardiogenic shock, then the blood cannot be ejected forward. So it will build up in the left atrium, the pulmonary veins, and the right atrium, and the central veins. So both the central venous pressure and the pulmonary capillary wedge pressure will be increased. Now, the hallmark of cardiogenic shock is decreased cardiac output, and that's why the cardiac index is severely decreased in this case. So extremely low cardiac output means decreased cardiac index. Now, the decreased cardiac output also causes reflex sympathetic overactivity, and that will cause constriction of the peripheral vessels and increase SVR. So that's just like hypovolemic shock. So you can think if a patient has shock and their sympathetic nervous system is intact, then by default, just assume that the systemic vascular resistance goes up and that they're having that vasoconstriction. Now finally, since the blood flows super slowly in those capillaries of cardiogenic shock, then tissues will have the opportunity to extract lots of oxygen. And so by the time it gets to the veins where you're going to sample it, then the mixed venous oxygen saturation will be low. So here we see an image of a patient with heart failure accompanied by jugular venous distension. And you can see that rope-like distended vein. Now, jugular venous distension, again, is due to the backflow of the venous blood and increased central venous pressure. And that pressure of the JVD on the physical exam is really an important clue for cardiogenic shock. And just to think in simple terms, if the blood's not going forward, then it'll just build up and you'll see it here. Now let's talk about how it actually presents, the clinical features. Well, just like hypovolemic shock, cardiogenic shock is also characterized by hypotension and the compensatory tachycardia because the sympathetic nervous system is intact, And also, because of that sympathetic activity, there will be peripheral vasoconstriction. So the patient will feel cold and clammy. And the diagnosis of cardiogenic shock is based on the combination of the patient's history, so the cause of the cardiac dysfunction, and the measurement of the vital signs and the hemodynamic parameters. Additionally, an ECG may reveal the underlying cause of the patient presentation. For example, an acute or previous MI, or congestive heart failure or arrhythmia. So the ECG can provide a lot of information about why the patient has cardiogenic shock, whereas those top three, the history, vitals, and hemodynamics, will tell you that the patient does indeed have cardiogenic shock. Management of cardiogenic shock depends on a specific underlying cause. And that makes sense because aortic stenosis, for example, would need to be treated different than a tachyarrhythmia. However, for most cases, the focus is facilitating forward blood flow and relieving volume overload. In that instance, you can use either milrinone or dobutamine. Those are positive inotropic agents, which can increase myocardial contractility, which would naturally decrease the lack of normal blood flow, so you get more moving forward. And the mechanism of action and other details that are important regarding milrinone and dobutamine can be seen in our pharmacology chapter. We have image mnemonics to help you memorize those details. But just by way of brief review, milrinone is a phosphodiesterase 3 inhibitor, and it increases cyclic AMP levels in the myocardium and the vascular smooth muscle. So that causes increased contractility and vasodilation. Dobutamine, on the other hand, is a beta-1 receptor agonist, and it also increases heart rate and contractility. So those are positive inotropic agents. Now, diuretic medications, such as loop diuretics, are also commonly used to relieve volume overload. But that only treats the symptoms of volume overload. It doesn't actually treat the cardiogenic shock itself. But keep in mind that you can use diuretics because of the volume overload caused by the cardiogenic shock. Now, if a cause of cardiogenic shock is a valvular defect, then of course you want to replace that defective valve. And if the shock is due to an arrhythmia, then you can use antiarrhythmics or perform cardioversion. So here we have a table summarizing the different types of shock that we've described in this lecture. And in the next lecture, we're going to expand this table with the other two types of shock that you need to know. But before we end this lecture, let's do a quick question. A 78-year-old man with a history of congestive heart failure is brought to the emergency department due to severe shortness of breath. The patient says he often forgets to take his medicines. Blood pressure is 75/60, heart rate is 140, and respiratory rate is 29. Echocardiography reveals ejection fraction of 15%. Which medication affecting both the vascular tone and the myocardial contractility should be administered to counteract this patient's cardiovascular compromise? Okay, so this patient has a past medical history of CHF, and he might be forgetting to take his daily medications, so it's not well controlled. And he presents with this severe shortness of breath and hypotension and tachycardia. So now we're suspicious of shock, and the echo reveals an EF of 15%. So all of that makes us think that he has cardiogenic shock, and the cause of his cardiogenic shock is likely an exacerbation of his CHF. But the question is about a medication that can help this patient improve the vascular tone and the contractility of his heart. So that would be milrinone. So recall that milrinone is a phosphodiesterase 3 inhibitor. It increases cyclic AMP, and that cyclic AMP increase is seen both in the vascular smooth muscle and the myocardium. So in the vascular smooth muscle, that will result in vasodilation. And in the heart, that increased cyclic AMP will increase contractility. So that patient will have improved tissue perfusion. And that concludes this section.